Happy afternoon. Today the topic is sperm preparation techniques. So in the introduction, I'll be just giving a brief about the different techniques, or why we'll start with an introduction to explain why we are going for the sperm preparation techniques. So why do we actually go for this processing of the semen sample? So, or we are separating the spermatozoa from a seminal plasma. It can be for the diagnostic reason or for the research reason to find out the functional competency, evaluation of different medias, and also for the sperm recovery for the assisted reproductive technologies like IUI, IVF, or even to assess like how the function of the sperm is, how good the sperm is. An ideal sperm preparation technique should recover maximum number of high quality sperm, and you need to choose a technique where there is a less damage that happens to the sperm, and it results in so that there is no much release of the reactive oxygen species, which will be released by the sperm or the leukocytes, which in turn can affect the quality of the sperm. And also to remove the debris or the unwanted sperms, unwanted immotile sperms, or else the cells or the tissues which is there in the semen sample. There are several methods or the techniques which is available for the separation of the high quality sperms. For example, swim-up method, density gradient, pentoxyphilin washing, electrophoresis, fluorescent cell sorting. So I'll be basically talking about those methods which can be done in an IVF center or an assisted reproductive technology setup. For example, swim-up, density gradient, magnetic assisted cell sorting, which is known as MACS, which are the commonly used ones in an IVF center. So why do we go for a semen preparation? First is capacitation. So normally in a natural condition, when the semen is ejaculated into the cervix of the female partner, the capacitation naturally happens while it moves from the cervix and enters to the uterus and reaches the oocyte, which is there in the fallopian tube. So as that technique or as that phase or the step is bypassed in the case of assisted reproductive technology, we have to wash the sperm and activate the sperm so that it will be able to identify the receptors which is there in the zona pellucida of the oocyte, and which later on results in the fertilization of the sperm with the oocyte, and hence results in the formation of the embryo. And this is in the case of IUI and IVF. And also it increases the sperm motility as well, so that the movement of the sperm is fast enough to reach the oocyte. Next is removal of seminal fluid. For example, if we are injecting or inseminating the patient with the raw sample, it results in the cramps in the patient. And to avoid this, we need to remove the sperm or remove the seminal fluid, by which we get the high motile sperms in very small concentration, which is actually useful for the insemination in the uterus during the process of IUI. And also to remove, to have a good quality of sperms with high concentration, and also to remove the debris and the cells. So we'll talk about the equipments that needs to be there, which is for the semen processing technique. First is the laminar airflow, where it gives a sterile environment for processing the semen sample, and also the handling the sperm processing media. Next is the light microscope or the compound microscope, incubator for warming the media, and also to keep the semen sample for warming after the at 37 degrees Celsius. Macular chamber that is for the counting of the sperms and to find out the most motility months after analyze during the semen analysis. Next is the Digi block. This is the test tube warmer where you can warm the sample and also keep the sample for incubation in case of in an inclined position, that is at 45 degrees, with the help of these DG blocks. Refrigerator, and then is the lab supplies where you have pasture pipettes, 15 ml centrifuge tubes, cement container or the sample sterile, which is sterile, and the syringe. When I spoke about the centrifuge, we always have different types of different models of centrifuge. So usually what we prefer in an IVF center is a swing out centrifuge with a sample. There are two types actually, the fixed and the swing out. So the one we prefer is a swing out centrifuge, where the tubes or the pellet will be formed just at the bottom of this tubes, whatever we use, whether it is a conical tube or a round bottom tube. In a fixed angle, you will have the pellet which is there in the slanting formation. So it will be very difficult when you are trying to remove the supernatant from the and the pellet gets disturbed. So the the pellet which is formed, which will be dispersed into along with the supernatant, which will be discarded. So preferably we need a swing out centrifuge. Now we often hear the terms RCF and RPM. So, and it gets confused as well. So RPM is something where it is the number of times the rotor is rotating or the spinning, and it doesn't matter what is the diameter or the G or the radius of irrespective of the rotor or the types of the rotor that we use. It is just, for example, if it is like 5,000 RPM, it is a number of times, that is it spins around 5,000 rotations in the centrifuge, because spinning will be there. Now, talking about the relative centrifugal field, it actually measures the gravitational force, and also it considers the rotor size. So, and it is mentioned in the unit G. So usually you should consider, so it is variable and it depends upon the size of the rotor and also gravity that is there. So it actually varies from one instrument to the other. So always you should consider the term RCF when you are considering for a centrifugation process. But there are equipments which does not give an option for an RCF. So you need to consider the radius of the rotor, then calculate and based on the centrifuge that you have in your center. So this is the formula where RCF is the RPM raised to 2 into 1.112 into 10 raised to minus 5 into R, which is the radius. Now, talking about the media that you use, generally there are two types of media that you use. That is a sperm wash media for the sperm washing, which is there for the sperm and the washing of the sperm, and the other one is the density gradient. So I'll talk something about sperm wash media first. So it was specifically developed for the washing of the sperm and for the incubation. And this media is something where you can handle in the room outside the incubator. That means its pH will not be affected in the absence or it does not require a carbon dioxide incubator. So it is something where you can handle outside the incubator, and the pH is maintained in its biological range, that is physiological range, that is the 7.2 to 7.4. It's just that you need to maintain the 37 degrees Celsius. And it actually, it's a modification of the herpes buffered HTF, that is a human tubal fluid. And it was as described by the Quince and the colleagues. And there are lots of commercially available media. For example, I have put a few, that is by Irvine Scientific, by Origio, Fujifilm, by Vitrolife or Vitromed, and Sage, to name a few. And the buffering system which is there in the sperm washing media is herpes. Yeah, as I mentioned, it does not require a carbon dioxide incubator. The other media which we use commonly in an IVF center is the density gradient media. It is sterile. It's a colloidal suspension of the silica particles, and it is suspended in the herpes buffered HTF. And you have two options actually. One is the 100% density gradient media, where you need not have to, you just have to dilute it according to the percentage that you require. That is, you can, with the help of, by adding Heppy's medium into 80% or 40% or 90 or 45%. Or else, if that is an issue, for a convenience mode, you have a already pre-prepared, that is 80% and 40% commercially available, where you can just go and purchase it. You can get it from the company, depending upon the whatever percentage that you want. And some of the instructions that usually you need to give for a sample collection is, the patients or the patient has to maintain an abstinence of about 2 to 5 days. So the couple has to be counseled regarding it, and the spoken and the written instructions has to be given regarding the proper semen collection. The sample should be collected in a room very near to the laboratory, so that the once after the collection, the sample can be immediately placed in the incubator. So the fluctuation of the temperature will not be there. And this patient should undergo serology test, that is the for the HIV, hepatitis B, HCV, VDRL, and the consent has to be taken on the day of the procedure. The sample which has to be collected by the masturbation, preferably, which is the method for the collection, in a sterile wide mouth sample container, and the container has to be labeled with the husband's and the wife's name, their identification number, abstinence, date, time of the when the sample has been, the container has been given, and also the time has to be mentioned or they recorded once the sample is being received, or the container is given back and kept in the incubator, and also at what time the procedure is being started, like the processing time. And emphasis has to be given that the complete semen sample has to be collected, and in case of there is any spillage, it has to be informed, because as an incomplete sample, you will lose a majority of the sperms, which is actually healthy enough to have a successful pregnancy. Now, the semen sample has to be handled by the embryologist or the technician in such a way that, considering it may contain a harmful infectious agents, and it should be handled with extreme care and as a biohazard. And the semen analysis has to be done, not like, for example, the count, motility, and the morphology can be assessed, based on which the method or the processing technique has to be chosen. For example, the media which has to be used, or which needs to be used for the semen processing, has to be warmed at least for 30 minutes at 37 degrees Celsius. Now, I'll give you an image of how the pre-washed semen sample looks like. You can see there is a lot of agglutination, a lot of debris, immotile ones, a lot of cells, pus cells can be seen. On the other side, you can see the post-wash semen sample, where you can see the count and the morphology, as well as the debris is not there. It's like highly, it's good quality, and free from all the agglutination and debris. Talking about the different procedures that we use for processing of the semen sample is, these are the commonly used ones: Swimmer method, density gradient method. Again, there are subdivisions in it, like double gradient or triple gradient. Even monolayer is also there. You have a third one, which is the simple wash. And these are the techniques which you can use for IUI, IVF, and ICSI. Now, how do we choose, like whether to go for a simple wash, or whether to consider as a density gradient, or whether we can go for a swimmer? It is based upon what the quality of the semen sample is. For example, if there's a sample count is normal and the motility is normal, you can go for swim-up method. So you will get a good quality of sperms. If it is like suboptimal quality, low quality, for example, low count, motility, and morphology, you can go for a density gradient method. Here, you will get a large number of, compared to the swim-up method, the number of motile sperms what you obtain is high from a poor quality sample. Talking about swim-up method in detail, it is based on the ability of the sperm to migrate, like how it can swim up into the media. So there are two ways you can do the swim up. It can be directly from the semen sample, that is a raw sample, or from the washed pellet of the sample, sperm. So how do you do the direct swim up? You have the sample which is being, you can take it in 1 ml or 2 ml of the sample, which is liquefied in the tube. And you can layer it with the equal volume, the volume of sperm wash media, layer it without disturbing the semen sample. You can keep it in a 45-degree angle, and you can leave it for 60 degrees Celsius, 60 minutes for at 37 degrees Celsius. And after that, when you see, you can see only the motile viable ones swimming up from the semen sample into the upper layer, as in the image shown. The other one is, here there is no process of centrifugation. That is a direct swim up method from the raw sample. The other method is, you have to wash the centrifuge the semen sample, get the pellet, wash it again with the sperm wash media, and it will be from the pellet you layer above the pellet you layer with the fresh sample, fresh media, and keep it for for 30 minutes for the sperms to swim up from the pellet. So this is in the image. You will have the sample, semen sample, equal volume of media is added, mixed very well. Centrifuge at 1500 RPM for 10 minutes. You will get the pellet at the bottom. You aspirate the pellet, add it into another tube which has got 2 ml of media, fresh sperm wash media. Again, centrifuge at 1500 RPM for 5 minutes. Get the pellet, layer it with 0.4 to 0.5 ml of media, incubate for 30 minutes, and leave it for some time at that 40-degree angle, so that you will have a more surface for them to swim up and come. Now, once after the 30 minutes, you can take the supernatants, transfer it to another tube, and then it is ready for insemination. In density gradient method, it uses the centrifugal force to separate the motile sperms based on the density. So, and you will have the immotile ones, the WS and the cells, all the lower grade sperms, which will be separated at the interface of the colloidal solution. So what happens is, the motile sperm pass through the fluid interface more easily, leaving non-motile sperms, epithelial cells, and other debris trapped at the interface. If more than one density layer is used, again the motile ones can pass that interface, but again there will be a filtration method, which happens at the next layer. So you will get much more viable and high quality sperms in the pellet. So it's actually like filtering the semen sample based on the density, and you will get the sperms in the pellet, high quality sperms in the pellet in the bottom of the test tube. And density gradient, which I said like 80% or 40%, or the 90% or 45%, whatever which is being used, it has to prepare just before the like 1 hour or 30 minutes for before the usage, and you have to keep it for warming for 30 minutes. The volume of the semen sample should not exceed, for example, when you are layering, you have the 80%. I'll be showing it in the next image. The volume of the semen sample, what you layer on this density gradients, should not exceed the volume of the total gradient. The other thing is, like, you need to have a liquefied semen sample. For example, in case of a viscous sample, you need to add a little bit, wait for it to liquefy. If it is not getting liquefied, even after waiting for 30 or 40 or 45 minutes, you can add sperm wash media, give a gentle mix or pipette in and out, mix it properly, leave it for some time and wait for its liquefaction. If not, again, you can use 18 to 20 gauge needle and you can do in and out in the syringe, where you can actually see which is actually a mechanical way of liquefying the semen sample. So this is what I was mentioning. You will have an 80% of the density gradient medium, which is layered in the bottom, layered by 40% above it, and followed by the semen sample. So this is how you can clearly see this different layers before centrifugation. Once after the centrifugation, you can see a pellet at the bottom, which has got the motile viable sperms. Non-motile sperms, the dead and the other cells will be there in the interface, and the seminal plasma above. Now, as I mentioned about the layers, it is centrifuged at 1800 RPM for 15 minutes. It's actually 300 G if I'm mentioning in the case of RCF. I'm mentioning this RPM according to this what we are following in our center. And for a wide, you will be aspirating the pellets out and then transferring into another tube which has got a sperm wash media. Mix the pellet gently with the media. Again, centrifuge for 1500 RPM for 5 minutes and discard the supernatant, leaving the pellet behind. Layer it with 0.4 to 0.5 media. Then actually you can go ahead with gently mixing it, and then it is ready for insemination. For a double way of getting highly motile and viable sperms, what you can do is you can combine the swim up along with this density gradient, where you can just layer it, leave it for 20 to 30 minutes, take the supernatant, and then you can go for insemination. That is another way of going for the having a highly viable sperms for IUI or even IVF or an 𝐒𝐻𝐫. Now, there is no fixed protocol as such, because you can take a call on based on like how the quality of for example, it's not that you should only use 80 or 40% or 90 or 45%. In case of a poor specimen or a poor semen sample, or with a low count, low motility, and they will not be able to filter in such a high concentration of colloidal solution, like density gradient in 90%, which is highly concentrated. So what you can do is you can have a 60% and 60%, 45% of this instead of an 80-40 or 90-45, where the colloidal solution of the silica particles concentration less, so that the sperms which are of low quality, low concentration, can pass through and go to the pellet for a better recovery. Or in the case of the semen samples with a low volume, you can go for a mini gradient, where instead of the 1 ml of 80% and 1 ml of 40%, you can have 0.5 ml of 80% and 0.5, totally forming a 1 ml. So the distance for the sperms to pass these columns of silica gel or the density gradient medium is lesser, so that the recovery of, in case of low volume and low count, is higher in such samples. The third method is a simple wash method. A simple dilution, it's a simple method where you just mix the sample, which is actually with the medium, which is already pre-warmed. And then you go for a centrifugation at 1500 RPM, 1000 RPM for 5 minutes. The supernatant is discarded. You can repeat the same washing step again, and you can mix it with, you can have the pellet with a fresh culture medium of 0.5 ml. So it can be a single wash or a double wash. And these methods can be used for semen sample which has got the optimal parameters, and with no much of debris or no much of leukocytes in it, or you have not much of an immotile sperms. And you can use this in the case of frozen donor sample processing. So this is the comparison of different methods, like in what case or what technique in which can be applied for which type of samples, and what are the advantages and disadvantages. Now, how do you process the infected case? For example, you get a seropositive case, hepatitis B positive case. How do you go for it? How do you process such samples? You can go for a triple gradient method, where instead of 80-40, you have now 3 different concentration: 90%, 70%, and 40%, 1 ml each. So you have 90% in the bottom. Above it will, next you will have the 70%, 1 ml, and then 40%, 1 ml layered, and above you will have this sample which is layered for the filtration process. And this is the this you will be doing in the 15 ml centrifuge tube, which I have mentioned earlier. Now you need to centrifuge at 1800 RPM for 15 minutes. Transfer the pellet into another tube, mix with 3 to 4 ml of sperm wash media, centrifuge for 1500 RPM again for 5 minutes. You have to repeat this wash step again. There will be 2 wash steps. Now the pellet, after the second wash, it is laid with 0.5 ml of sperm wash media kept for swim up. The supernatant is used for the procedure later. According to the WHO, for processing of HIV positive semen samples, there has been sperm in the semen sample, viral RNA and the viral DNA can be seen in the seminal plasma and the non-sperm cells. But there has been studies or the previous cases where 3,994 women with HIV discordant couples, they have conceived through ART. About 56.3% of clinical pregnancy were reported with no HIV and seroconversion occurring without plasma viral suppression. Now, you can have a combination of DG and swimmer for this, so that you can leave all the non-sperm cells removed from it when you are keeping for the swim up, and only this you can get the viable sperms in the after the swim up in the upper layer. These procedures were developed to separate virus-infected non-sperm cells and the seminal plasma from the HIV-free motile spermatozoa in the swim up. So this method can be used, but in case of HIV samples or the seropositive cases, you should take utmost precautions to handle such cases because of the chances of, to minimize the risk of cross-contamination of the HIV samples, and also people who are handling these cases, and also not to infect the partner after this procedure. Now, talking about the testicular biopsy samples, in case of azoospermia, obstructive azoospermia, we have, or in the case of DA5, we go for a testicular biopsy. There is a mechanical method as well as the enzymatic method. So even the processing, when you're handling the tissues, you need to, in mechanical method, you will be teasing the seminiferous tubules or the tissues that you are having. You macerate the tissue with the fine needles or with the help of the glass slides. And then you will be centrifuging, you will be adding little media into it. After the maceration, you will be transferring it to the centrifuge tube. You centrifuge at 100 to 300 G here. For 10 minutes, you will be the centrifugation. You will be putting a lesser centrifugal speed to handle or to prepare such cases, because the sperms are much more vulnerable for the damage, and also there are high chances of having the sperms that you have is all most of them will be the immature ones. So to withstand the centrifugal speed and all, it will be a bit difficult. So try to keep a lesser centrifugation speed so that it can withstand such a this step, and so that we'll get a viable motile sperm. Now again, after the centrifugation, you will get the pellet. You discard the supernatant, and the pellet that you can wash, go for a second wash, provided you have a better motile sperms in the pellet. If not, you will be losing more sperms in each centrifugation step. And you should resuspend the pellet in 0.2 to 0.5 ml of fresh medium later. In the enzymatic method, to instead of this maceration or the teasing of the tissues, you will be going, treating the sample or the tissue with a collagenase solution, and you will be leaving at 37 degrees for 1.5 to 2 hours, vortexing for 30 minutes. Then you will be centrifuging it for 100 to 200 G for 10 minutes. Gently discard the supernatant. You wash it with the culture medium so that you will block the activity of the enzyme further. Resuspend the pellet, again in the media, washing it again at 100 to 300 G for 10 minutes. Resuspend the pellet again and add 0.2 to 0.5 ml of fresh media. Now, in case of retrograde sample ejaculation, the sample in such patients, they'll be considered they cannot produce the semen sample because it will be entering into the urinary bladder. So in such cases, once it enters the urinary bladder, it will be acidic and it becomes, the sperm will be non-motile. In this such situations or such conditions are there in case of the patient with diabetes or who has got the spinal cord injury. Now, in such cases, the patient should be counseled for going for an alkalization of the urine, where the patient will be asked to drink water with sodium chloride and sodium bicarbonate 1 to 2 hours before the ejaculation. Patient should be advised to go for an ejaculation first, and then immediately collection of the urine sample in the sterile containers. And then you have to go for the, you should concentrate this urine sample, pellet it by centrifugation, wash this pellet again with sperm wash media, and then check the pellet for the presence of a motile sperms. There are some other techniques, 2 more techniques, which I'll be explaining with that as a specialized sperm processing technique, which is the MAX. First one, that's the magnetic assorted cell sorting. It is an immunogenic immunomagnetic technique which allows the selection of sperms that do not show signs of cell damage. That is, you are able to see the motility, morphology and all, but you are not able to see the DNA damage in case of a semen analysis. So in such cases, MAX procedure is being used to choose the sperms which has got the DNA which is intact and free from any DNA damage. What are the indications for the MAX? Patients who are to be treated with artificial insemination, patients who have high level of DFI, patients who have repeated miscarriage, and in case of unexplained infertility, and who had a previous treatment cycle with a poor embryo quality or no embryos as well, where you cannot have any reason to say from the oocyte this quality. So it is based on, like, to identify the sperms, which sperm membranes which has got phosphatidylserine which is present in the outer surface of the membrane in the bilipid layer. It is be identified by annexin, which is a phospholipid binding protein. This annexin B is conjugated with the supermagnetic microbeads. That means it has got a magnetic bead attached to the annexin. This annexin again in turn goes and binds to the phosphatidylserine, which is observed only in the sperms which has got a apoptotic which is apoptotically marked, or which has got the damaged DNA. So this is a setup where you have MAX in it. You first do the density gradient, followed by MAX separation. That is, you will be, as in the image, you will be loading the semen sample, which has been treated with annexin and incubated for some time for 30 minutes with the annexin V beads, which is a magnetic beads. Once you are passing through the column, which is actually fixed in a magnetic field, you will have this annexin bound, non-viable or damaged apoptotic sperms stuck to the sides of the column of this which you are running, and the fluid which you, or the sperm which you will be collecting at the bottom in the tube, it will be sperms which are which do not have a DNA damage. As in the image, you can see the damaged DNAs on the sperms are attached in the column. The one which is free flowing will be free of DNA damage, and you can use that sperm which is collected in the tube for the IVF or an EC purpose. Now, the second method which I will be explaining is the microfluidic sperm sorter method. Here it is based on this principle or the normal human spermatozoa is separated on the basis from the debris on the basis of fluid, the principle called fluid dynamics in the microenvironment. Here there is no process of centrifugation. That step is bypassed, so that the sperm is not subjected to high-speed centrifugation, which can damage the DNA. And this technique is applicable to those samples which has got a normal motility and morphology. So as you can see, you can add the sample at slot A. You will be adding media in the slot B, and the motile ones swim up through the into the slot C, and you will get the immotile ones in the slot D. So in the end, I'll be concluding by saying we spoke about the different methods that we are using in an IVF laboratory, and which what and all modifications you can do for a better recovery of the semen sample with viable and highly viable and sperm with the intact DNA. So it is easy to set up a sperm preparation laboratory and perform sperm preparation. However, special expertise is required especially in the case of handling or processing of epididymal and testicular specimen for ART procedures. Specimens exhibiting severe oligospermia or hyperviscosity and retrograde ejaculates may require more intensive laboratory manipulations to recover sufficient number of motile sperms. It is important that the method of a choice for processing be determined on the individual basis, which is dependent on the sperm concentration and motility, morphology, and semen volume. It is not like a single method is applicable for all the semen sample. So it depends upon the person who is handling, like the technician or the embryologist, who determines what sample requires what method. Not only results of the previous semen analysis, but also the quality of the specimen presented on the day of the processing must be considered. No single separation technique is always superior. The technique that yields the most normal motile sperm should be used. And the technical andrology laboratory experience clearly provides an advantage. Thank you for your attention.
Thank you, Ms. Neena, for that wonderful talk. I hope these insights were very useful to all our participants. I want to remind our participants that there will be a Q&A session after the second talk. You can post your questions in the chat window and we will address it at the end of the session, requesting all the participants to keep the discussion interactive by posting your questions. The next session will be by Dr. Jahnavi Esanakula, who is a fertility specialist at GarbhaGudi IVF Centre, Electronic City branch. So the next session is going to start by Dr. Jahnavi Esanakula, who is a fertility specialist at GarbhaGudi IVF Centre, Electronic City branch. Dr. Jahnavi, over to you.
Good afternoon, everybody. I'm Dr. Jahnavi Esanakula. Now we are going to talk about IUI procedures and techniques. So what is IUI? It is a commonly used treatment for infertility where the semen from the husband or the donor is artificially inseminated into the uterus of the female partner. What is the importance of doing a scan on the day of IUI? First thing is we can check for ovulation. Second thing is we can reconfirm the position of the uterus, whether it is anteverted or retroverted, and it makes our procedure of doing IUI much easier. Third, we can assess the endometrial lining on the day of procedure as well. Though we do it before giving trigger, we should do an endometrial assessment on the day of procedure as well. What are the signs of ovulation? We look in the transvaginal scan. We look for collapsed follicles. Collapsed follicles with irregular margin will confirm ovulation, and presence of free fluid in POD also confirms the ovulation. Then we'll have to take informed consent, whether it is for artificial insemination with husband sperms or artificial insemination with donor sperms. We'll have to take the consent that is mandatory. Second, how is semen collected? What are the points to be remembered when semen collection is being done? Semen should be collected by masturbation and after proper abstinence. We'll discuss about the abstinence again. Collection and IUI should be done in the center, preferably. We use sterile containers for collection, and we avoid using toxic materials like condoms and jellies because they will be harmful to the gametes. What is the abstinence period that is required? Usually, we advise the patients to have 2 to 5 days of abstinence. Shorter abstinence, with very short abstinence, what is the problem is there will be low count, but we'll have good motile sperms and better morphology, especially if the DNA fragmentation or something is high for the patient. It's better to have a shorter abstinence period. So we usually advise the patient to have 3 days or less abstinence period. That will be the best sample. So meanwhile, you can ask the patient to try naturally also at home. So consecutive, if the patient has, in special cases like the patient has very less count, you can ask the patient to give 2 samples and process them together. That is called pooled sample processing. That also will help in patients with oligozoospermia. Then what are the things to look for in post-wash sample? First, we have to reconfirm the identity of the patient. Then we'll check the post-wash sample under microscope to see for motile sperms. If more than 5 million motile sperms are there, that indicates it's a good sample. There is something called total motile spermatozoa count. So this total motile sperm count is calculated by multiplying the volume with concentration of sperms and percentage of motile sperms and dividing by 100. So if this count is more than 5 million, what does that mean? That means the number of motile sperms present in the sample is high. Then it gives a good result. Then it indicates that our IUI result is going to be better. So this was done as a meta-analysis in 2004. It includes 16 studies where they have studied post-wash total motile count of 0.8 to 5 million. Motility could predict the failure to become pregnant with specificity of 100%. However, the sensitivity of the test was limited. You can see here, if the total motile sperm count is very less, then the chances of pregnancy per cycle are also very, very less. If the total motile sperm count is more than 5, then definitely the chances of pregnancy is definitely increased. Then the next question that comes commonly while doing IUI is timing of insemination. Then shorter the collection to insemination time, better will be our pregnancy rates. If we delay semen processing for about 30 minutes to 1 hour, then delay IUI also from 90 minutes to 2 hours after collection, then the chances of pregnancy rates are reduced. The pregnancy rates are reduced because there will be damage to the sperms. Sperms have to be processed immediately after liquefaction, and sperms have to be injected immediately after processing. There were some studies where they have identified semen collection to sperm wash and sperm wash to IUI times, and semen collection to IUI times were studied, and shorter the interval between the sperm collection and IUI time, better will be the pregnancy rates. That was the study outcome. Then what is loading versus insemination time? Waiting for 15 to 20 minutes between loading the catheter and placing the process sperms into the uterus will result in significant loss of sperm motility and compromise the results with IUI. So if the IUI is being done, it is better to do the IUI processing of the sample and IUI in the same center, because the transfer of the sample from one place to another, one because of temperature and the other because of time factor, will decrease the pregnancy rates. Then timing of insemination when we have to do the IUI. First, the thing we all know is survival of ova is maximum 24 hours. So usually what we do, we time the IUI, time the ovulation with HCG injection and do IUI around 36 to 38 hours later. There is something called double insemination where we can do 2 IUIs in the same cycle. Double insemination is usually done after 14 hours of HCG and 36 hours of HCG. All these timings are calculated based on HCG itself. If we are dealing with a male subfertility and need better results, then we can plan IUI after 24 hours of HCG injection and 48 hours of HCG injection. Suppose we have planned for a single IUI. And on the day of IUI, after 40 hours of HCG also, after 36 to 40 hours of HCG also, egg has not ruptured. Then what are we going to do? At 38 hours of HCG, we will see that the egg has not ruptured. So we can do one IUI there. And then the next day again, 24 hours later, we can do one more IUI. Okay, that is called double IUI. That is called a flexible protocol. If we are not timing by HCG, if we are using urinary kits to determine the ovulation, then if urinary kit is used, once the kit comes positive, one IUI can be planned 24 hours later. Single versus double IUI. Theoretically, there are advantages with double IUI because ovulation may not be synchronized if more than 2 follicles are there, 1 or 2 follicles are there. Ovulation is not going to happen exactly at the same time. It may not be synchronized with the HCG we are giving. Then in a natural pregnancy, in a natural intercourse, what happens is all the sperms will get deposited in the cervix, and cervix keeps in the crypts of the cervix, and the sperms keep releasing from the crypts and they will be available in the female reproductive tract for about 72 hours. Now, when we are doing IUI, we bypass the cervical mucosa. So the availability of sperms for 72 hours cannot be ensured. So when there are multiple follicles, it makes sense, theoretically at least, to do multiple IUIs. That is at least 2 IUIs. Then what will be the optimal time for double insemination? The first IUI 12 to 18 hours after the HCG injection, and second IUI 34 to 60 hours later. This is a single versus double IUI for pregnancy. This is a systematic review and meta-analysis. According to the studies, though theoretically we have listed some advantages, according to the systematic review done and published in 2017, there was no evidence of a difference between single IUI and double IUI in terms of clinical pregnancy and live birth rates. Double versus single IUI for subfertile couples. This is a study Cochrane published in July 2021. Clinical pregnancy rate may increase in double IUI group, but there was low quality evidence. It is uncertain. We don't have enough evidence to say double IUI is better and single IUI is inferior. Frequency of IUI. This is what I was talking about previously. When we fix a protocol, if you have previously decided itself that we have to do only single IUI, then we will do a single insemination at 36 to 40 hours after HCG injection. If we have previously fixed itself that we are going for double insemination, then we will do 24 hours and 48 hours post HCG 2 IUIs. If we have not decided, we were waiting for ovulation or there is delayed ovulation, then comes a variable protocol. We do a transvaginal scan at 36 hours post HCG. If the patient has ovulated, then we will do single IUI. If the patient has not ovulated, then we will do one IUI and then IUI then and one IUI 24 hours later. Sorry, that is a mistake. 24 hours later, we do the second IUI. inseminated volume. Similar, when the volume of post-process sample was assessed, there was similar pregnancy rates for 0.5 ml and 3 ml of inseminated semen. So normal volume which we are going to inject is usually 0.3 to 0.5 ml of processed sperms. Let us discuss about IUI catheter now. IUI catheter is non-toxic, atraumatic, sterile, disposable, and it has there is a rigid cannula, that is stiff cannula for IUI also, which can be used in difficult cases with difficult access. Soft cannulas have less trauma to endometrium in case you are touching the fundus, or in case you have difficult access, then you have to use, in case you have difficult access, we usually use stiff catheters, but the trauma damage to the endometrium can be a little higher using stiff catheters. But studies have shown that in experienced hands, there was no statistically significant difference between soft and firm catheters. These are the IUI catheters, 𝐒𝐻𝐞𝐫𝐦 catheter, which we use. Steps. The IUI room should be well-lighted room with gynecological examination table for the patient to be placed in dorsal lithotomy position. We should use non-powdered and non-toxic gloves to avoid damage to the gametes. The patient should be with full bladder. Many of you will be wondering why the patient has to be full bladder. See, this is an image of an anteverted uterus with partially full bladder. You can see there is an anteversion and anteflexion, which makes us difficult to do the IUI. We cannot go inside very easily. Now with the full bladder, what happens is this axis is straightened, so it makes our job easier to do the IUI. Even with the soft catheter also, it will be very easy to enter the internal os. The next thing is ultrasound guidance. Visualize in ultrasound, we can visualize the movement of the cannula into the cavity, and thereby we can also prevent touching the cannula to the fundus, and less trauma to the endometrium will be there. It may have higher pregnancy rate, but they were not significantly different from blind insemination. So what does this mean? If you already have an ultrasound and it is accessible, then you can use it. But just for an IUI, study indicates that it is an added cost, except without any benefit for the pregnancy days. Steps. First, we have to insert the cuspospeculum. Obviously, after taking consent, after confirming the patient's identity, we will use the cuspospeculum to visualize the cervix. Then we will prepare the vagina, but not with betadine, just with normal saline. Then we will reconfirm the identity a second time just before injection. We will load the processed semen sample into the IUI catheter, and using 1 ml syringe, we will do the IUI. We will pass the catheter through the cervix and cross the internal os, but we should not touch the fundus. If you have ultrasound, you can do it under ultrasound guidance. We will inject the sample over 1 to 2 minutes. We will withdraw the catheter slowly, keeping the pressure on the plunger so that by capillary action, sperms are not entering the catheter again. We will advise bed rest for the patient for just 10 to 15 minutes, after which she will be allowed to pass urine. Again, why bed rest is advised? Because after insemination, spermatozoa may reach the fallopian tube in just 10 minutes. So this 10 minutes, if the patient has bed rest on the table, that is going to help the pregnancy rates. Again, there is contradictory evidence. This is a study which is published in 2009, where there was immobilization versus immediate mobilization after IUI was studied. There they have studied 199 couples who had 15 minutes of immobilization and 192 couples who had immediate mobilization. The ongoing pregnancy rates were significantly higher in immobilization. Again, this study was replicated in 2017, and this is a article published in Human Reproduction, where they have studied 244 couples with 15 minutes immobilization, and after IUI, and 254 couples who were mobilized immediately. This study showed that there was no significant difference. Number of IUI cycles. Again, this is again one more common question asked by the patients and practicing clinicians also. Where to stop? If we don't know where to stop, you cannot subject the patient to 4, 5 cycles of IUI, 6, 7. We have had patients who underwent 9 cycles of IUI also. So pregnancy rates reduces after 4th cycle of IUI. So we usually recommend 3 cycles of IUI, but if the patient is a good candidate, you can recommend a 4th cycle also. Irrespective of whatever protocol you have used, if the patient has not succeeded in the first 3 cycles, the next cycle, the cycle fecundity per cycle for next 4 to 6 IUI cycles will be just 5.6%, which is much, much lower than a natural intercourse also. What are the side effects? What are the complications of doing IUI? There are certain complications of the procedure, certain complications because of the stimulation, and antenatal and prenatal complications. Antenatal and perinatal are just like a non-natural intercourse pregnancy. What are the complications of the procedure? There can be a very slight chance of infection if the patient parts preparation is not done properly. Pain and psychological also complicated. Patient may be feeling dull and depressed because she is undergoing a procedure. Uterine camping is seen in 5% of the patients. Spotting is seen in 1% because of difficult IUIs. Gastrointestinal upset, infection is just 0.2%. Risk of ovarian stimulation can be ovarian hyperstimulation syndrome. But recent times we have good protocols, which we will discuss later, that decreases the risk of ovarian hyperstimulation syndrome. The chances of multiple gestation is always there because there is a chance that more than one follicle is developed during the cycle, and there is a chance of ectopic pregnancy also. What are the other factors which affect success other than the number of IUI cycles she underwent? Couples, the cause of infertility also determines the success rates of the IUI. The clinical pregnancy rate per treatment cycle is, if you see, 12.3% for unexplained infertility, 16.4% for cervical mucal hostility, 10% for immunological infertility, 21%, this is the highest clinical pregnancy rate per cycle, for mild male factor infertility, 13.3% for ejaculatory failure. The second determinant is age. Increasing female age and increasing male age both decreases the pregnancy rates because of the obvious causes of the quality of the gametes involved. If the age of the woman is more than 37 years, it is shown that there is a drastic decrease in pregnancy rates. Here in the table, you can see less than 30 years, the chances of clinical pregnancy rates on an average is around 15%. 30 to 35, it is 13.7%. 36 to 39, it falls drastically to 7.8%. And after 40, it is just 2.1%, which is very less. Then duration of infertility, the chance of conception decreases with duration of infertility. If the patient has infertility duration less than 4 years, the chances of pregnancy is 14.2%. If the patient has more than 4 years duration of infertility, the chance is 6.1%. Treatment cycle rank. This also we have just discussed. Majority of the pregnancies occur within the first 4 treatment cycles. And after that, whatever we are doing, whatever IUIs we are doing, the chance of pregnancy is very, very less. Sperm parameters, total motile sperm count and morphology are most important in the result of IUI. Bleeding. If the catheter traumatizes the endometrium, then obviously the implantation rates will decrease. See, this is the IUI success. Patient selection is the first and most important determinant of an IUI success. Then next, what are the factors which we have to we consider while selecting the patient is, what is the type of infertility? What are the male factors and female factors in the infertility? Then comes the other determinants like patient preparation, luteal phase support which we give, site of insemination, IUI, number of IUIs per cycle also, timing of the IUI, whether we have properly timed and properly did the IUI, interval between HCG and IUI, semen preparation, which our embryologist has discussed already. IUI sample also determines the result. Immobilization, catheter washing, duration of infertility and age of the patient also determines the success of the IUI. Then if we are practicing IUIs, definitely it is common to encounter difficult IUIs. Now, what is easy and how do we differentiate these two? When we use tenaculum to hold the cervix, when we use uterine sound because we could not negotiate through internal loss, when we touch the fundus while doing an IUI, when there is back spillage of semen, when there is, after doing IUI, when you notice there is a blood on tip of the IUI cannula, when there are abdominal cramps, and when there is spotting post IUI, all these indicate that it was a difficult IUI. Studies whether are inconclusive whether we have to take do it under ultrasound guidance or not. I have already shown you studies, contradictory evidence on that. In all these cases, if there is a difficult IUI, the chances of conception are lowered when compared to an easy IUI. How do we manage difficult IUI? Suppose you have difficulty, you have performed one IUI already and noticed some difficulty. Then in the next IUI, you can do it under ultrasound guidance. If at all there is cervical stenosis, which is causing us difficulty to negotiate with the internal loss, then we can plan one cervical dilatation prior under anesthesia if there is cervical stenosis, and then proceed with IUI. You can use stiff catheter. You can use the tenaculum to hold the cervical loss. Then in case of retroverted uteruses, we can use half-filled bladder. But full bladder helps to straighten the axis in only anteverted uterus. But if the uterus is retroverted, if we fill the bladder too much, then it can cause even more retroversion and will not be able to enter the internal loss. So there, half-filled bladder can be beneficial. Then regarding the protocol, there are certain queries when we practice whether to use metformin, whether it is going to have any impact in our success rate. Metformin co-treatment, Cochrane says it does not improve the pregnancy rate or live birth rate, but it reduces the risk of moderate and severe 𝐒𝐻Ss. So whether you use metformin with clomiphene, or you use metformin alone, or you use metformin with other ovulation induction drugs, it is not going to improve our pregnancy rates or live birth rate, but it's just going to reduce the risk of 𝐒𝐻Ss. Role of metformin: decreases VEGF concentration, thereby decreases the incidence of 𝐒𝐻Ss, decreases insulin and androgen levels, decrease in aromatase activity, decreases the number of antral follicles before stimulation. In follicles, there is microenvironment, which is highly estrogenic in women with PCOS. Metformin helps to convert that androgenic environment to estrogenic in PCOS women. Then what is this recommended protocol? Now we have letrozole, which is being increasingly used for IUIs. Letrozole plus gonadotropins definitely is recommended for IUI. What happens when you use only gonadotropins is you will need more number of injections, and the cost of the stimulation will go very high for the patient. Using ovulation or supplementing with ovulation induction drugs is going to decrease the cost of stimulation. So less amount of FSH requirement is there. Less number of follicles, mature follicles will be there. Thereby we can avoid 𝐒𝐻Ss also. Low levels of E2. It will be more physiological for the patient also. There are no deleterious effects on endometrium, and there are comparable pregnancy rates from only gonadotropins to letrozole plus gonadotropins. Then the other question is, all of us know that we have to do a tubal patency. We have to confirm tubal patency before doing an IUI. But how to confirm whether to go for HSG or a laparoscopy? There are certain recommendations. There are no strict recommendations, but there are recommendations given by RCOG. Women who are not known to have comorbidities like PID, previous ectopic pregnancies, endometriosis should be offered HSG. That is, if the duration of infertility is less than 4 years, then we can have an option of doing HSG for such patients if she doesn't have any previous risk factors. Women who are thought to have comorbidities should be offered laparoscopy because it gives us a more holistic idea regarding her anatomy and what is wrong with the patient. Then let us discuss few interesting cases in IUI. I'm just going to discuss at a couple of interesting cases which we treated and had successful outcomes. One Mrs. X, age 30 years, and Mr. Y, age 35 years, came here with in history of primary infertility for 5 years. They were both software engineers, and there was a lot of stress, traveling, and altered sleep pattern. When we took the history of wife, she had irregular cycles with bleeding for once in 1.5 to 2 months, with 6 to 7 days of bleeding each cycle, and there was no history of dysmenorrhea. There was a history of increased weight gain and acne since 1 year. Family history: mother and maternal aunt also had irregular cycles, but both conceived naturally after 4 years of marriage. Both parents had diabetes and they were on medication. There was no history of infertility in family. Husband had history of mumps 15 years back. There was no history of smoking or drinking. Family history: there was father has hypertension. There was no other infertility history in the family. Coital history was fairly normal. Treatment: the patient, before coming to our clinic, she had multiple cycles of ovulation induction attempted with clomiphene citrate 100 milligrams for 5 days in the last 3 cycles, but there was no follicular growth, so the cycle was cancelled and the couple did not have any IUIs or natural intercourse before that. Examination: the wife, the general physical examination was okay, except that BMI was 32, acne and hirsutism were noted, and except for these 2 things, the general physical examination was normal. Investigations: on ultrasound, with the history itself, we suspected bilateral polycystic ovaries to be present, and it was confirmed by ultrasound. And see the AFCs. There are around 16 to 20 follicles on both sides with very massive ovaries. Around 30 cc was the volume of the right ovary, and left ovary was around 20 cc. The rest of the investigations were normal except for oral glucose challenge test, which was a little higher. The cutoff was 140. Here the patient had 148 milligram per deciliter. Thyroid, we would like it to be less than 2.5. So except for that, the general tests were normal. Coming to reproductive endocrinology, FSH was 6.8. LH, obviously she's a PCO woman, we expected LH to be higher, and it was confirmed again in the blood test. LH was 13.35. E2 was normal on the 2nd day of her cycle. Husband general physical examination had asthenozoospermia, probably because of the previous mom's history. Total count was 18 million per ml, and total motility was 32 with progressive motility of just 28%. So this is a stimulation which the patient underwent at our clinic. So the patient started on day 3 of her cycle. There was no dominant, no cyst or anything. So we did a scan and we started the patient on letrose along with injections, FSH on alternate days, 75 interaction units on alternate days. On day 9, we saw the patient, there was no dominant follicle. So we extended the letrose for 2 more days. So we gave extended letrose regimen, and we also increased the dose of FSH by to 87.5 international units. Then on day 11, we saw 1 follicle on each side which was growing, and the endometrium was also 7 mm AAA. So we continued the same dose of FSH. Then we shifted to HMG on day 13 when we saw 15 mm follicle was growing on right ovary, and again 12 mm follicle was there on the left ovary. On day 15, we saw 1 mature follicle of 20 mm and 9 mm triple line endometrium. So we triggered and timed the IUI with HCG injection. First IUI was done after 14 hours after HCG injection, and second IUI was planned after 36 hours after HCG injection. Luteal phase support was started on the day of second IUI with dihydrogesterone, 10 milligram TID, and micronized progesterone also, 400 milligram vaginal twice a day we have given. UPT was positive after 15 days of IUI, and there was a singleton pregnancy noted on scan, and cardiac activity upgraded 16 weeks. highlights of whatever we have learned from this is PCOS patients are a little difficult to manage, but low dose step-up protocol is definitely helpful for stimulation of PCOS patients, which yields to less number of mature follicles. Thereby, you don't have to cancel the cycle. Lifestyle modification, laparoscopic ovarian drilling also can be done to such a patient as an alternative to stimulation with FSH. Extended letrozole to 7 days of letrozole instead of 5 days is also very helpful. Triggers. HCG trigger is given when you have less than 3 follicles, less than 3 dominant follicles, and there is no signs of OHSS. If you suspect sign of OHSS, or if you suspect that there is more than 3 follicles which are developing and you still want to go ahead with IUI, then you can think of doing a trigger with agonist. But most likely, if there is more number of, if there is development of more number of follicles, like more than 4 follicles, we usually tend to cancel the cycle because that is much safer for the patient. Second, this is a second case. Couple aged 28 years and 30 years came with a history of past infertility, primary infertility for 3 years. Husband was an OT technician and wife was a nurse. So there were more night shifts and stress. There was wife had irregular menstrual cycles once in 2 to 3 months with 2 to 3 days of bleeding, and there was no history of dysmenorrhea. There was no significant past medical history. Family history, mother had history of early menopause and she attained menopause at 34 years. She had one unmarried younger sister and there was no history of infertility in family. Husband, there was no history of smoking or drinking. There was no history of infertility in the family. Coital history was normal and the couples used condoms for the first year of marriage. Treatment history, wife, she underwent 6 cycles of ovulation induction attempted with letrozole for 5 days. There was no scan done during these cycles and egg growth was not documented or monitored in this patient. So we examined, general physical examination was normal. And when we did an ultrasound, we saw bilateral reduced ovarian reserve with uterus was normal and AFC just 2 to 3 on both sides. Ovarian volume was reduced on both sides. So we did a complete hemogram and viral markers which were normal. OGCT, thyroid, prolactin, everything was normal. Look at her AMH. When we did reproductive endocrinology, AMH was 0.7, which was very less. And FSH, LH both were raised, which confirmed our diagnosis of reduced ovarian reserve. Then husband general physical examination was normal. Investigations were also normal. Semen analysis showed teratozoospermia with the normal forms of just 1%. Count and motility were normal, but the normal forms were just 1%. So this is how the stimulation of the patient went on. On day 3, we saw the patient where she had an AFC collective of 5 AFC with 2 millimeter endo. We started with letrozole and also injection FSH 50 international units daily. We started with a higher dose daily because in the previous case also the patient is a documented clomiphene citrate resistance. She has not had ovulation with clomiphene citrate previously. And this patient, since she has reduced ovarian reserve, we started with a daily FSH 75 international units dosage. On day 9, we saw that there was no dominant follicle. So we changed the FSH to, we increased the FSH to 150 international units daily, and we continued the stimulation for 2 days. On day 11, we saw a 12 millimeter follicle, which was noted on right side with a good endo. We continued the FSH stimulation for 3 more days, after which on day 14, an 18 mm follicle was documented with a good 9 mm triple line endometrium. And then we triggered with HCG 5000 international units and planned a single IUI for this patient at 36 hours. Luteal phase support was again given with the same drugs, dihydrogesterone as per our protocol, dihydrogesterone and micronized progesterone 400 milligram vaginal twice a day. UPT was positive after 15 days of IUI. Singleton pregnancy was noted on the scan and cardiac activity was noted at 6 weeks. And now the patient is an ongoing pregnancy. So these are the 2 successful stories of 2 different kinds of patients. One is a PCOS patient with too many eggs ruining her ovulation. The other is a reduced ovarian reserve patient who has very less number of eggs to deal with. Thank you. To summarize, there are certain things which we have to keep in mind while doing IUI, because our result is mainly dependent on the patient selection of the patient, which case you take up for IUI, then processing the sample, then proper injection of the IUI and proper timing of the IUI is always of paramount importance. Then only we'll have result.
Yes. Thank you, Dr. Jahnavi. Now let's move on to a question and answer session. We have a small quiz right now. So, dear doctors, you'll be able to see the questions on your device. So, we have, dear doctors, I would also like to announce that we have few questions pending in the chat box. So we will take up those questions immediately after once this quiz is done. So please stay connected. So your first question for the day, IUI to be done after how many hours of positive LH kit? Your options are A 38, 24, 40, 60. You can choose one of those options.
Answer is, I think most of the people got it correct. Answer is B, 24 hours.
So we're up with the next question. If follicle not ruptured in scan after HSG, double IUI is planned at. Your options are 12 and 24 hours after HCG, 36 and 40 hours after HCG, 24 and 48 hours after HCG. The last option is 38 and 60 hours after HCG. Dear doctors, the correct answer is option D, 38 to 60 hours after HCG. Moving ahead with the next question. Normal volume of processed semen injected into the uterus. Your option is 3 to 5 ml, 0.3 to 0.5 ml. Third option is 1 to 2 ml, and the last option is 0.1 to 0.2 ml. Dear doctors, the correct answer is 0.3 to 0.5 ml, option B. Up with the next question. After IUI, motile sperm take how much time to reach the fallopian tubes? Your options are 36 to 40 hours, 3 days, 10 minutes. The last option is 1 hour. Dear doctors, the correct answer is option C, 10 minutes. With next question, all of the following factors will increase the risk of failure except option is immobilizing for 15 minutes, catheter tip stained with blood, use of uterine sound. Fourth option is touching the fundus with the IUI catheter. The correct answer is option A, immobilizing for 15 minutes. What is the percentage of gradient media used in triple gradient? Your options are 90%, 60, 30%. Option B, 80, 40, 20, 90, 70, 40, or 90, 45, 30%. The correct option is 90, 70, and 40%. With next question, what is the buffering system in sperm wash media? Your options are bicarbonate, HEPAS, phenyl red, amino acids, and salts. Dear doctors, the correct answer is B, HEPAS. How to process the semen sample with low volume? Your options are simple wash, mini gradient, double density, swim up. Dear doctors, I would request you to quickly answer within 10 seconds once the question is displayed, as we are running short of time. So the correct option is mini gradient. What is the protein which binds to
Phosphatidylserine.
So the correct option is annexin, B. So we come to the last question of the quiz rounds. So what is the principle behind microfluidics sperm sorter technique? The options are fluid dynamics, magnetic migration, gravity, and sedimentation.
Chat box questions are there.
So the correct answer is fluid dynamics. So with this, we come to the end of the quiz sessions. So dear doctors, with that, we come to the end of today's webinar. So before we move towards the closure, we would like to answer a few questions that have been asked in the chat box. So with the first question, does AMH play a role in selection of IUI? Over to you, Dr. Jahnavi.
Hi, Doctor. AMH, yes, definitely AMH plays a role in selection of IUI. But more than AMH, the age of the patient also plays a role in selection of IUI. If the AMH is low, definitely we will tend to err more on the side of IVF than IUI. But if the patient is young and has not tried IUI, we can try 1 or 2 sessions of IUI for young age patients because they respond very well. The quality of oocytes is very well and they can conceive with IUI itself. There is no need to go for IVF. So AMH does play a role, but also does age of the patient in selection of IUI. Go up a little bit. The patient wants to do only OI with IUI. Previous 2 IUI cycles failed. Please let me know the management for LUF and anovulatory cycles. See, first thing is patient wants to do only OI with IUI. That is for us to convince the patient to go for an IVF if IUI is not working out. But first we should see why IUI is not working out. The patient is 32-year-old bilateral PCOS with irregular cycles. Has the tubal assessment been done? That is one thing we have to check. Is there any male factor which we are neglecting? That is also one more thing we have to check. If the male factor is good, if the tubes are good and has been documented by doing a proper laparoscopic assessment, then definitely yes, 2 more cycles or 1 more cycle of IUI, definitely this patient can try. If all the 3 or 4 cycles of IUI fails, then we definitely have to convince the patient to go for an IVF. Then how to manage anovulatory cycles? Like I have showed you in the stimulation, you can start with letrose and add FSH or HMG to the patient. If the patient is bilateral PCOS, like you have described, doctor, please add 75 international units of HMG or FSH during her stimulation on day 5 on alternate days. You can start from day 5, do alternate days, but please be very cautious while using FSH because the patient should not hyperstimulate, and don't use more doses of FSH. You can stick to the protocol which I have shown there. If she is ovulating with just letrose also, that is just fine. There is no need to add. If she is not ovulating with letrose, then extended letrose you can add, and you can also add FSH. If the patient is bleeding, the next question is Saraswati Verma. Dr. Saraswati, the patient is bleeding at IUI. What to do due to difficult IUI? First question is whether the patient is bleeding from the cervix or the endometrium. If the patient is bleeding from endometrium, then the chance of pregnancy is definitely very less. So you try to do an ultrasound guided IUI. If there is difficulty in negotiating the internal loss, then you will have to put her under anesthesia and try to dilate the cervix. That is called cervical dilatation you have to do. Then you should do one IUI under ultrasound guidance, full bladder for anteverted uteruses and partially full bladder for retroverted uterus. Then properly position and properly visualize the endometrium and then proceed for IUI. That will help us decreasing the damage. If needed, you can use a stiff catheter also, that's okay. But you should hold the tenaculum and then use the stiff catheter. Then how to soften the cervix at IUI, at difficult IUI. There is no procedure to soften the cervix. You cannot use misoprostol and all because they will stimulate the contractions and sperms will be expelled out. So you cannot soften the cervix and you cannot use misoprostol or anything to dilate the cervix, doctor. That is not going to give us good result. So it is better to go for cervical dilatation in the prior cycle only to do a effortless IUI this cycle. I hope your question is answered, doctor.
Thank you so much, Dr. Jahnavi, for patientfully answering all those questions and clarifying the doubts. So With this, we come to the end of today's webinar. So this is a series of webinars and will be held on last Tuesdays of every month at the same time between 2 p.m. to 4 p.m. I request you all to make time and participate. We are confident that we can share the knowledge and the expertise that has enabled us to have such high success rates in all aspects of infertility treatment. On behalf of GarbhaGudi IVF Centre and GGIRHR, I thank all the speakers for their insightful talk, as well as for all those doctors who participated in today's webinar. A special note of thanks to all the HODs of medical colleges for their valuable support. So the next webinar will be on January 31st, and the topic will be tips, tricks to increase success rates and evaluation of male infertility. See you all next month. See you. Wishing you all a very happy and prosperous, healthy 2023, a very happy new year. Stay safe, stay healthy. Goodbye.